So welcome everyone. I'm going to hopefully give you an overview of what's involved in a developmental assessment, and then obviously be able to answer any questions. I thought it would be quite helpful just to start off by thinking about the aim of assessment, because I know that many families come to us with slightly different ideas about what they want to get out of the assessment. I guess for a lot of people it will be to explore whether there is an underlying neurodevelopmental condition that might explain particular challenges that their child is facing. So the assessment may well lead to a diagnosis if that's felt appropriate. I think for a lot of people, the benefit of the assessment is to develop a greater or deeper understanding of their child's particular profile of strengths and difficulties, and from that to be able to then develop a support plan. So it's I guess in most situations people are coming to us because there is a concern. Sometimes it is a curiosity, but that's unusual. There's usually a concern, whether that is a concern about a child's functioning at home and at school, or one or the other. That varies. And we do have questions on our forms about what you're hoping to get out of the assessment, and that's really helpful. So that can help us to just sort of make sure that we're doing our best to absolutely meet those aims. So I just thought it might be quite helpful just to talk a little bit about the different types of assessment in general, but also at Starjumpz. So I think when people are looking for a neurodevelopmental assessment or an autism assessment, they will probably be advised that the assessment should follow NICE guidance. Now, the NICE guidance is actually interpreted quite loosely by the people have different interpretations of it. The NICE guidance on the assessment of autism is actually extremely comprehensive, and it covers an awful lot of things which a lot of NHS assessments just can't possibly meet. And actually a lot of independent assessments, they may stick to part of it but not to it in its entirety. You'll also probably come across people saying that it needs to be with a multidisciplinary team. Interestingly, the NICE guidance actually doesn't say it has to be with 2 people, but we find that doing the ADOS with 2 people is really important, because it just adds to the quality and the robustness. But it is possible to have a single assessment. The assessments that we do at Starjumpz are 2 professionals, so there would be a paediatrician, so either myself or Dr Veronica Leclexio, and then usually it's one of our highly specialist speech and language therapists who've been ADOS trained. Sometimes might be a psychologist or an occupational therapist. But at Starjumpz we also have other types of neurodevelopmental assessments. So we know that for some families the full paediatric joint assessment may not actually be necessary, or it might not be achievable. So there are different ways to have a developmental assessment. So my colleague Dr Anna Russ and Vanessa Carter, they do a combined autism ADHD assessment. Then there's Emily, who is a clinical psychologist, and she does a very thorough autism assessment. And then there are options to have the ADOS on its own, which is not a diagnostic assessment, but sometimes that might be the bit that families are waiting for in an NHS pathway, and then if they have that with us, that could then be used to sort of as part of their NHS assessment. Or with the preschool children, we'll often, because for preschool children it's not really value for money to have a full neurodevelopmental assessment, because there's not so much, there's not so much that we can do. There's not, so for example, if you have a 2 or 3-year-old child, we could be doing some sort of assessment to think about ADHD, but it's very unlikely that it would be appropriate at that age. So, and a lot of the other assessments of mental health are much more applicable for teenagers and older children. So we are sort of doing more and more for the preschool children, having a slightly different approach where they have the ADOS with 2 speech and language therapists, or a speech and language therapist and an occupational therapist, and then an appointment with a paediatrician before or usually afterwards to look at all of the paperwork and meet the child and do some other shorter assessments, and then reach a conclusion. So what are the components of the assessment? Well, the way I like to think of it is that we are trying to piece together a puzzle, and there are lots of pieces and they're all really important, and to have a very thorough, robust assessment you need to have as many of those pieces as you can. It's not always possible, but ideally you would have them all in place. So the pieces are the history from I should have actually put in there the child, so obviously where applicable, we really want the child's voice to shine through our assessment. So history from child and family, history from school. So I think that's an important thing just to mention, because we do see a lot of children who are home educated, and so it can be a little bit more challenging to get background information, or they might be out of school because they're in burnout, and so it's not going to be possible to get somebody who's currently working with the child in school or in other education facilities to complete the background information that we would usually request, and sometimes that worries people. So there's always ways around it, because what we're really just trying to gather is as much information as we can. So actually having information from somebody outside of the family is really helpful, because it's their view of how that child is functioning away from their parents. So if they are in school, then it's a comprehensive form that we ask a teacher who knows the child well to complete, but it could be a swimming tutor, or it could be family member or a friend who sees the child on a regular basis, or if they feel that those questions are not applicable for them, or they're too detailed for them to answer, they could just send a letter outlining their observations and experiences of this child. Other professionals, so it's really helpful to have copies of past reports. I think sometimes people might worry about sending those in, especially if they've perhaps already had an assessment that hasn't reached a conclusion that they're happy with. I would say it's always really helpful, and I think it makes for a much more robust assessment if you've included, referenced and considered that previous assessment. We will always be fresh eyes, but sometimes I think it's probably more worrying to other professionals reading the report if they subsequently find out that actually this is the second assessment this child has had and we've not known about it. So referencing that first assessment, and then if we do have a differing opinion, actually being able to really clearly and carefully justify that different opinion in the report is I think safe and robust. We send out a lot of questionnaires in advance of the appointment, and that's for us, there are ones that relate to mood, to anxiety, to sensory processing, behaviour. It's for us to get as thorough a picture as we can. We do some what we call unstructured observations, so just general things about the child, about how they are in the waiting area, whether they've been able to greet me, how are they looking comfortable, are they looking relaxed, are they looking really anxious, how are they when they come into the clinic room, are they immediately curious, or do they sit very quietly, do they need what sort of level of support are they needing from their parent. And then we try to be as absolutely flexible as possible, because we want this assessment to be an enjoyable experience for the child. And obviously some children are very happy to come, and you can see from the moment they're there, they're enjoying it. And for others, it's a really difficult experience. And so we're very sensitive to that. And we want to do whatever we can to make a child feel most at ease, because we're going to get much more valuable information if a child is feeling comfortable. In an ideal world, we want to have some time with the child and their family and the child on their own, because that replicates school. And sometimes we know that children are presenting in a very different manner in school to how they are with their family. And so actually for us to see what they're like with their parents and without is really helpful. So for some children, there's a really stark difference, and that helps us to understand why school may or may not be seeing challenges. And for others, there's no difference. But it's how they are with and without their parents, but it's also how they respond to the separation that can be really helpful. But we would never force that, and we hope that just a child will feel comfortable. And we do use, the first bit of the assessment, the child is just away for about 10 minutes in a nearby room, and then that's with the other professional. So that allows me time to have some time just to talk to parents about their concerns without a child present, which can be helpful. And then when we do the ADOS, if possible, the two professionals, we will stay with the child, and the family, the parents have a break. But there's no set rules around that. So if your child is not going to be able to separate from you, then we will accommodate that and give you instructions whether to step in and help, or whether actually for this particular part of the assessment we need to not give any assistance. And then also with the observations, I certainly make a point of thinking about how has the child been before and after the break. So we have quite a long break in the middle of the appointment whilst the ADOS is discussed and jointly scored, and then the child and family come back afterwards. And that's helpful because sometimes perhaps if a child has felt or been a bit on edge in the first bit, they may seem more relaxed later on, or there may be no difference. But that can just also help in building that picture. And then also find out the observations made during the feedback. So at the end of the assessment, when explaining all the findings, is just helpful to see how engaged a child is in that process, or if they're much younger and they're not so interested in the conversation, what are they doing to occupy themselves during that unstructured time? That's really helpful. And then we do the structured assessment. So we do the BPVS to begin with. So that's a British Picture Vocabulary Scale. I'm going to talk through each of these things in detail, but then we do the ADOS 2, which is the Autism Diagnostic Observation Schedule. And for children 6 and above, we try the QB check, which is a validated screening tool for ADHD. And we do physical examination, and then we do usually a fine motor task, which is also a really helpful observation of a child listening to instructions and then executing instructions. And then just very occasionally there might be some other things that we feel are going to be helpful as part of that we might add in. So there's comprehensive background information is requested in advance, and I know it's quite arduous, but it's so helpful. And I score all of that in preparation for the assessment and will have read all of the documents. I make notes and I try my best to remember everything, but it can be many hundreds of pages. But it does mean that I've got a good sort of grasp of the concerns or challenges and strengths before child arrives, and then that is really helpful for lots of different reasons. But what really does matter to us is the child's experience of the assessment. So what we don't want to be doing is spending a lot of time talking about negative things and talking about worries in front of a child while they're listening. So actually we try and keep all of the history taking that happens in the assessment as really positive. So just talking about what you're good at and what you like doing. So that's the aim of the getting all of the part of the aim of getting all of the information beforehand. Some families fill in that paperwork in great detail, which is really helpful. For others, it's it's quite brief. I would say that the more information that you can give, just the more thorough an assessment it is, really, because it's more for us to consider. We get you to complete lots of different questionnaires. So I've just got a list of them here. So we do ADHD rating scales, we do an autism questionnaire, we do an anxiety scale, moods and feelings, we do the extreme demand avoidance questionnaire, and a sensory profile. And then depending on age, we've got some others that are really helpful. So the CAT-Q is particularly helpful for teenagers because it explores camouflaging and masking and is really helpful. And then with the history, so the background form that parents and carers will fill in covers everything really, but it is trying to sort of find out about early life history and then current functioning. So I think sometimes people might look at the questions and think, oh, that say for example their child is 14 or 15, they might look at the questions and think, oh, this is really not relevant for our child because it's talking about kind of quite basic skills, but there are particular questions that might be relating to now, but there are also a lot of questions about in the past. So it is helpful, even though you may have a very able child, to still fill in those things as best as possible, because that really helps us to paint a much and create a much richer picture of child's strengths and difficulties. And then I've mentioned a little bit about the assessment already, but these are the components just to get outlined again. So the unstructured observations, gathering some further history, the BPVS, looking at fine motor skills, the ADOS, the QB check, and physical examination. And these are just a few of the things that we would be thinking about with those initial unstructured observations. So we do have various interesting items in the clinic room, and it's fascinating. Some children come in and sit and don't move, and others immediately notice things, the sensory pictures on the wall, or the little fiddle items that are usually on my desk, or boxes of things, and are very curious, and that it just helps us to just gather a little bit more information about their personality. So then the BPVS is a really helpful screening tool that we use. It's actually a screening of understanding of single words, and it's validated and standardized, so we can get a standardized score and we can get an age equivalent. And we do that because it immediately gives us a better idea of a child's level of understanding of language. There's also a strong link with verbal IQ, so it can give us it's not completely robust, but it gives us an idea around cognitive ability. But it also gives us a lot of behavioural observations, so it's very interesting different ways in which children may approach this task. So the task is that either myself or speech and language therapist working with me will say a word, and the child has 4 pictures and they have to choose the word that best matches, and there's a correct answer. Some children point, and they point in exactly the same way, or they may have a very fancy way of pointing and they do that throughout. Others will chop and change and will say the number of the picture, and then they might point, then they might describe the picture. Some children don't want to say anything, don't want to point themselves, but they might get a favorite cuddly toy that they've brought with them to give the answers for them. Lots of different ways. Some children will approach this and only do what they've been asked to do, which is identify the pictures, and other children will start chatting about the pictures and ask questions, and suddenly they'll see a picture that sparked a memory and they'll start talking about that. Some children might seem oblivious to the fact that we're writing down answers and that there probably is a right or wrong. Others are highly sensitive to that and you'll see them peering over and trying to check whether they're getting them right, or they'll actually repeatedly ask, how many have I got right? And we just try to keep everything as positive as possible. But it's a very helpful tool that we use right at the sort of start of the assessment. And then we do the ADOS, which is, again, it's a very structured assessment, a validated assessment tool. And there are different modules depending on your child's age and level of speech. And some they have an overlap in terms of some of the tasks, but not all of these things will be used in the assessment. Most of the time we're doing what we call a module 3, which involves some play with toys, a puzzle, looking at a book, looking at a picture, some chatting, creating a story, a demonstration task, looking at some cartoons. The older children and young people don't do the play bit, and it's more talking. But they will still do the book, the picture, creating a story, and the cartoons and the demonstration task. And we work through that. One of us will be actually doing those tasks with the child, and the other is watching and taking notes. And it's really helpful because we can miss things. So some of the things that we're looking for, you have to be actively looking. So facial expressions and how they're directed or not directed, gestures. When you're in the middle of a conversation or in the middle of play with a child, it can be easy to miss those things. So having the other person whose sole focus is watching and writing is helpful. So because then once we've finished all of the tasks, child has a break and we then discuss the findings, and it's a very methodical way that we have to go through that and score. And then we're scoring as to whether there is a very obvious autism related sign, and that's all that we've had training to identify, and it's very prescriptive, and we have to have the evidence to give a score. Most of the time we probably have consensus, but there are, in every assessment there will be probably one or two areas where we may be deliberating a little bit and going through the evidence a little bit more, because there are certain things that can be a little bit more complicated. But then we agree our scores, and then from those scores there's what we call an algorithm, and that pulls out a certain number of the scores and they're added up, and then you'll hear people talking about a cutoff. So depending on which module, module 3 for example, the cutoff is 7, and you're looking for a score sort of in excess of that to be consistent with evidence to support a diagnosis. But it's not an exact science, and we know that some children with ADHD, the score can be higher than it probably really is because of some of their ADHD related symptoms that have interfered, and sometimes the ADHD can actually artificially lower the score. So there's a lot to it that we have to discuss and work out. And this is just an example of one of the tasks in the ADOS. So this is looking at a book, and that's the picture that we use. So it's the same. We have one book for the younger children. Actually, we have 3 books. One for the very young children, one for the middle childhood children, and then one for older children and young adults. But it's the same, and wherever you have an ADOS, it will be the same kit, it should be, and the same way that it's scored and performed. And then we do a fine motor task. So we have a 4-page little booklet, and there's a little bit like the BPVS, there's lots of things that we get to sort of extra information from doing this, but it's very straightforward. We ask a child to copy a series of shapes, then write their name in a particular area, and then copy out capital letters, copy out numbers, and do a drawing. But there are a few little things in that task that tell us a lot. So it tells us a lot about child's ability to remember the instructions, to listen to the instructions in the first place, how keen they are, their speed of working, how they're holding their pen or pencil. There are a few little red herrings in the task, and it's whether the child notices. It's really interesting. Some do, some don't. Some may not appear to have listened to the instructions and just assume they know what to do, and then struggle and miss the kind of attention, you know, the finer detail of the instruction, but at the same time notice something that's a little bit unusual about the way that the letters are printed. Or it's amazing how many things you can tell just from this little task, but it's really helpful. And then we do the QB check. So the QB check is a standardized computerized assessment looking at symptoms of ADHD. We describe this as the world's most boring computer game. There are two forms of it. There's for the 6, so it's validated from the age of 6. Not all 6-year-olds will be able to do it. Some manage it amazingly well. Others it's just too hard, but equally we can have teenagers that can't do it because they're just too impulsive. It's quite hard. The younger ones have circles that appear on the screen, and they have to press when they see a circle and not press when they see a circle with a cross, and the images come quite quickly. And then the older children have a series of shapes, different color shapes, and they have to press when they see a repeating shape. So it's all about attention, ability to inhibit the impulse to press when you don't need to press, but it also is tracking movement. And at the end, it gives us a really helpful graph, and it compares to a validated sample base, and then we can look at differences. And it gives a score out of 100. Anything above 10 is suggestive of ADHD, and the closer you get to 100, the stronger that evidence is. But it also then gives us a breakdown of movement, of impulsivity, and then attention. And it gives us these clever graphs over time, so you can actually see for some children their difficulties with inattention are present right from the beginning, and for others they maybe have a really good performance for 10 minutes and then they can't sustain it. But that can be helpful when you're thinking about planning study times and when to have a break, etc. So there's again a lot of information that we can get from this. We've been doing this for a long time now, so I think it's coming up to 9 years since we started. I started using the QB check, so we have done thousands, and we see patterns, and it's really interesting the different patterns you can get, whether you're autistic without ADHD, autistic with ADHD, or ADHD. And that's something that the company, I've talked to the company about, and it's being replicated. So it gives us a lot of helpful information. And some children can't do it, but actually I always encourage them to try. It can be really hard to anticipate whether a child is going to be able to do it or not. I'm caught out all the time, kind of think to myself, really don't think this is going to work, but I do want to try it, and then child actually sails through it. And other children where I think, oh, it's not going to be difficult, and they just can't access it. But actually just watching what happens is evidence that we can then include in our analysis and in the report. And then we do physical examinations. So we'll be checking growth, head circumference, blood pressure, heart rate, listening to child's heart, just looking at their general appearance. So have they got any unusual physical features, birthmarks, palm creases, shapes of fingers, ears. So the reason that we're doing that is we want to obviously exclude an obvious physical condition that might be contributing, but also looking at potential syndromes or chromosome imbalances or sort of indicators that could suggest that. Also, I would say very common for us to see hypermobility, and I think it's really important to identify. There is a lot of evidence linking hypermobility with autism. There's more evidence now coming out about more sort of complexity, that hypermobility with dyspraxia, with ADHD and autism and other things. And so actually it's really helpful to identify. It's also important because it could just be, it's another thing that a child is having to work harder to overcome, or it's another thing they're having to cope with if they've got achy, tired muscles. It's a cause of fatigue. So when you're thinking about everything that a child is actually having to cope with on a day-to-day basis, knowing that they're hypermobile is really important. I always am fascinated by the fact that I can have same age child with the same list of conditions, and yet the way that those conditions are impacting them can be completely different, and the way that they're presenting in school can be completely different. And so it's really important that we think, why is that? So the more that we can find out about everything a child is dealing with, I think it leads to much more useful recommendations and things that are going to make a difference. Sometimes you may have a child who is autistic and ADHD, functioning actually very well, but what's having the biggest impact for them is the fact that they're struggling with their handwriting because they're hypermobile and they've got some fine motor difficulties and they've got perfectionist tendencies. So it's really stressful and frustrating for them because they want their handwriting to be neat, and they see their classmates get their pen license and they're not getting their pen license, and that's the thing that's having a day-to-day impact on them, not their autism and their ADHD as such. So actually they may have get their diagnosis, but if you haven't identified that, you're not really going to be able to put in place everything that you need to do to mean that their life is going to be a bit easier. So yes, just so we're also, I always think it's a good opportunity just to have a brief health check. Sometimes we find something that is not related to neurodevelopment, but also important to identify. So every so often we find something very interesting and for us exciting, but actually important to identify and to refer on and include in a plan, because it could be another thing that is having an impact. So reaching a conclusion, how do we do that? Well, we are basically taking all of the evidence that we've got from, so all those pieces of the jigsaw puzzle, and we are trying to build a picture of the child's functioning and how all of those things will be interacting and affecting them. And when we're thinking about a diagnosis, we use the DSM-5 diagnostic criteria, and we're looking for the evidence that those criteria are met. And I think that's important to stress, because the DSM-5 criteria for autism, you have two sections to it, and the first section, section A, is your communication, your non-verbal and verbal communication, and your social interaction. You have to meet the criteria in each of those sections, but the range of difficulty within each of those sections is broad. But in the next section, you have to meet 2 of the criteria. So, and that's where I think sometimes it gets so complicated, because it means that you can be autistic without a special interest, because special interest is just one category. But so often we get mainly schools saying, but this child doesn't, this child doesn't look autistic to me, or this child isn't like another child I know who's autistic. And then they might have a little bit of doubt over the validity of a diagnosis. But actually it's really important, when you look at those criteria, it helps you to understand why there's such a variation in presentation of autism. But we're looking for we have to have the evidence that fits into those criteria. But you can have all of the evidence, but actually I would argue that you wouldn't have a child coming for an assessment if there was not an impact. But there has to be an impact to make a diagnosis. So that's where, if you hear people saying, well, we're all a bit autistic, aren't we? We might be, but if it's not having any impact on our lives, then we wouldn't be seeking a diagnosis. So when we mean impact, we are thinking, is it affecting your functioning? Is it causing complications in terms of your mood, your anxiety levels, your ability to meet your potential in school or meet your potential in other aspects of life? We then have to be clear that these symptoms have not just, say if we were seeing a 16-year-old, have we got evidence that these symptoms and signs have been present from early developmental period? That can be complicated, because we know masking is really complex, and for some children in the right environment, their autism doesn't necessarily show. It's always a little, we have to think carefully about that. I would say that most of the time, if we have a child where, and it's quite common for a child to nobody to have sort of noticed really anything very different through primary school, and then things become really challenging for a child in secondary. And often that is because there's ADHD as well, and there's very complicated ways that ADHD can mask some of the autism symptoms. But we really need to think about that, because if you have a child where absolutely the evidence is that there was nothing, and then all of this has happened at age 14, 15, then you really have to be thinking about, is there something else that could explain that? And people may have heard of PANS, PANDAS, so there's things, and other kind of more mental health psychiatric disorders that we would need to be thinking about. The other diagnostic criteria that we have to satisfy is that there is no other explanation. So by other explanation, we mean sort of other developmental conditions or intellectual disabilities that might explain the picture. And then we have to be thinking, is it in the best interest of this child to make this diagnosis? And I would say it usually is, but there might be some very specific situations where maybe it's not the right. It may still in the future be in their best interest, but it might be at that moment it's not. And so we are really sensitive to that, and would always be looking to discuss that more, because we really do want to ensure that by making a diagnosis, reaching a conclusion, that that's going to be a helpful and positive outcome. So sometimes, I'm particularly thinking about teenagers, they may not be ready for that. It's also important to say that if you're if you're planning an assessment, thinking about an assessment, thinking about how you want to hear the conclusion. So I feel that when a child has worked with us all morning, and they usually have been given some reason for coming, which we do sort of ask about at the beginning, but I feel that they need some feedback. But completely respect families' views on that, that they may not have used the words autism and ADHD yet. Sometimes they've been having those conversations for quite a while, and the child is prepared that that might be something that we will be talking about at the end of the assessment. But it's really important that we know where you are with that, so that we can give some sort of, it might be that we just give some sort of feedback, looking perhaps at the QB check pictures and telling a child how well they've done and what we've noticed about their strengths. And then they go, and maybe they go with one parent and go and have a walk, or maybe they sit with headphones and watch a film while we're talking. But we will adapt so that that is as comfortable as possible. Other children, even from quite a young age, are involved in that feedback process. I think what we want to avoid is a very sort of stressful, worrying end of an assessment when a child is then sort of pushed out of the door and knows that the adults are talking about them, and then because of the way that all the adults are looking and sounding, that must be really worrying, because that could feed into there's something wrong with me. And we want this, I feel really strongly about when a child learns about their neurodiversity, that it's positive. But it may be that it's on that day isn't the right time for them yet. And I do think that it's important that parents are ready for that, because their child's probably going to have questions, and if they're not ready and prepared to answer those questions, then it might be that it's best to wait and parents process that information and feel confident that they can have a positive discussion about that with their child. And it's done, and some parents prefer to sort of a drip feed approach, and maybe you'd use different words to explain it first of all. It really varies, but we want it to be comfortable and would respect individual families' views. So important to let us know. And sometimes people they'll send an email in advance and say, they're worried about anything being discussed in front of their child, because the child is so sensitive to these types of things, and we will accommodate. So I thought it might be helpful just to talk a little bit about what I kind of think of as special considerations. Say that the majority of children that we see cope with the assessment. Lots do enjoy it. For some, we are then sort of like, oh no, that felt like we were torturing them. We really weren't, but we hope they're okay. We do try really hard to make it as enjoyable and relaxing as possible. But there are some children that we see where they are so anxious and stressed that they're not going to it's not going to be possible to do everything in the way that we want or ideally want to do it. So again, we try to be as flexible and accommodating as possible. We get some children who really not compliant and can't engage. We have various ways. I mean, I think we haven't been beaten yet, but it's been close. But we have done assessments out in the garden, sort of out in the grounds. We've done assessments in the car. We've done many assessments in the sensory room. So if the sensory room is not being used, we will relocate there. We kind of try lots of different ways. We have assessed quite a number of selectively mute children. It's challenging because obviously we can't get a lot of the answers, but some children will write the answers for us. but we adapt and just try to get as many observations and as much information as we can. Preschool children, I think it probably works, certainly 2-3-year-olds, I think it works better splitting the appointment, and that's something that we're starting to do more and more. So you come on one day and have the ADOS with the speech and language therapist, and then come back on another day and see me, because it's a long time. It's, you know, the assessments are 4 hours. It's a long time for a young child. So I think that works quite well. A lot of times we get contacted in advance of the assessment, sort of just asking questions about girls, and will girls that mask, and will we see that? And we do. I think that we've been obviously doing this for a long time. I think that in those situations there are extra questionnaires that we might ask for. It's really helpful if a family let us know that they suspect that their child is going to be masking with us. We will usually see it, but actually it's helpful to have that on the forms, and it usually is there, and it's usually evident because the school will fill out a form without any evidence on it of anything that they're seeing. So it, you know, there are clues to us. And then, so I would also say that we do see quite a number of children who have learning disability, and that obviously, depending on the level, can make the assessment much harder to access. But again, we have ways around that. But we would always discuss, you know, if there's something that you anticipate could be particularly challenging, then talk to us about it, because we would see if we could come up with some way of making it as easy as possible. And then next steps. So as I said, I can have the same age child, a same boy or girl, with exactly the same list of diagnoses or associated challenges, and they will be completely different from the next child. So I feel that it's really important that you get a profile of your child, what their strengths are. You know, not obviously you know those already, but what we as professionals see as their strengths, what we see as the challenges, what we see as the impact, why it's having this group of conditions is having this impact. Because we can have children where they are seemingly functioning very well at home, but not in school, and at risk of exclusion because of the challenges they're facing, or the complete opposite, where they are masking and extremely compliant in school, but really distressing and challenging behaviour at home. We can have children where there are challenges in every environment. It's really important that you have it. I always think that the diagnosis is opening a door, but actually once you're through that door, how has it helped you? I know it has, because you have to get through the door, but you need more than that, and I think having the profile is really important. It's really important for parents, but it's particularly important for the young person, for them developing that understanding of themselves. So many times we hear of children who've made an assumption that something is happening because of something else, usually that, you know, feeling that they're bad or mad. So actually helping, you know, there's sometimes the sense of relief that they get when they realize that there's scientific reason for this. It all makes sense. It's very powerful. And I don't think that you can fully understand a child unless you have that unique profile, because otherwise assumptions will be made, not necessarily by parents, but by other people in that child's network, maybe based on their experience of working with an autistic and or ADHD child. So I think and interestingly, that profile is in NICE guidance, but it's sometimes a bit that's missing, because it's hard. It is hard to pull all of that together. But what I'd hope you would go away from the, obviously not, you get the feedback around that, but you then get in the report is that picture of why are these things happening? Why is school so stressful for this child? Or why is it that in this environment things are so much easier for this child? Because it's from that you build the most useful strategies and recommendations. So we try to give as much feedback as we can at the time. Obviously there might be reasons why, if the assessment has been particularly complicated or challenging, that we may not get as much time to do that, or maybe if child's not coped with the assessment, but we would always sort of offer to do that on the phone afterwards if that's not been possible, or to come back, but we do try to give as much of that feedback on the day as possible, and then sharing the information with the child in a way that that either coded or open, however, whatever's going to be comfortable. Some in that feedback, some immediate sort of ideas about things that can help, but then in the report. So I do a summary, which I try to get out to as soon as possible, but I would say within 2 or 3 weeks of the appointment, and that has all of the recommendations that are then in the report, so that you can get started on those, because the full reports, they are very detailed documents. They're I guess probably on average they're about 55 pages, and both professionals have contributed to that, and then we both have to check it. So it does take a lot of time. So that comes out around 8 weeks after the assessment, but we've been working on it during that time. And then we don't sort of, we're not prescriptive about follow-up. NICE guidance does recommend it, and I think it can be helpful for lots of different reasons, but it's if it was free, I would be saying it's important for everybody. But actually, in the old days with my NHS work, we would have routine follow-ups after every assessment, but then for capacity reasons that stopped, and it's a shame. But I think when we're working independently, I obviously, if parents want to come back and have an appointment with me, that's absolutely fine. We'll do that. But there are probably other avenues that you'd be better investing your money in. So, like an occupational therapy assessment or some speech and language support. But we'll talk about that at the time. But some parents do want to have or book an online appointment to talk through things, and that's fine. We'll try and accommodate that. So it's just on an individual basis, really, but we do have some avenues to support that. So that might be another way of, different type of follow-up. So thank you for listening, and there might be some questions, which I'm happy to answer.
Hi, Georgie. Hello. I'm just going to take this one out.
Hello.
Bigger. Hi. Good evening, everybody. My name is Jo Brett. I'm an occupational therapist and CEO at Starjumpz. And as you've seen from the presentation that's just run on what's involved in a neurodevelopmental assessment, I'm here with Dr. Georgie Siggers, who's a consultant neurodevelopmental paediatrician. And thank you for joining us, Georgie. We have some questions for you. I don't know if there's anything you'd like to say before we start.
No, just happy to get chatting about it.
Great. If you've got questions and you're watching, if you post your questions on Facebook, I'll be able to pick them up and pose them to Georgie. But we already have some questions that have been asked. And the first one is, why do you think it's important to assess for autism and ADHD at the same time?
Okay, so what we now know from research is it's much more common than we thought to have both conditions. And from my experience, some of the children who are most impacted by their neurodevelopment have both. And there are particular complexities that are associated with both, but also patterns of presentation that can make it much more complicated. And so whilst if we were to diagnose autism and ADHD, we have to have the evidence to meet both diagnostic criteria, but there can be some sort of slightly unusual aspects that if you were just looking at a child and thinking if they're autistic, you could actually feel that you're not seeing all of the evidence of autism in isolation, because there can be factors that ADHD is sort of either overcoming or hiding. And so it's really important to be thinking of both together and whether the story makes sense. So there are a lot of children whose pathway to the assessment might be just a little bit more complicated, because maybe there have been periods when there have been a lot of concerns and then fewer concerns, because maybe at that time this child's autism and ADHD are kind of functioning quite well together depending on their environment. So it's really important to kind of think of both together. And also it's about that formulation at the end, which is obviously just recently been talking about, where you're trying to come away from that assessment with as much practical advice. And actually, if we're only looking for one condition, you're only going to get the recommendations associated with that. Whereas if we're looking at the whole child and everything that is happening for that child, I think you get much more useful advice and a much better understanding of where your child's strengths and challenges are.
Yes,
and for the child themselves. Yeah.
And then the support and recommendations are going to be so much more valuable for school and for home and for the child.
Yes. And it's also really important to know that if you are autistic ADHD, but you are being supported just from an autistic perspective, your needs are unmet because your ADHD is not being supported, and vice versa. And so actually I would say that some of the children I see who are most likely to reach crisis or in crisis have had years of unmet need, and some of them may already have a diagnosis of one of those conditions, but there's been a big piece of the puzzle missing.
Yes. Yeah. What are the other sort of common overlapping presentations that you might see if you're doing a holistic assessment like this for the child?
Yes, that's a good question. Yeah, and I would say that it's very unusual to find just evidence of autism and ADHD. There, I always kind of talk about the neurodevelopmental conditions coming with friends. So the things that we would see, we may not be able to diagnose a dyspraxia because or developmental coordination disorder, DCD, because you need to have the evidence of the motor standardized assessment of motor difficulties to evidence the level of difficulty. But sometimes we'll see a child who's actually already had an occupational therapy assessment and there's the evidence there, so then we can include that and make a diagnosis. following a paediatric assessment, or we will make a recommendation because we've seen enough to suspect it. Yes. And we can include, because there is that possible risk, we can include that in the formulation and explain why we think things are particularly difficult. Hypermobility, as I mentioned in the talk, and we've got another talk planned about the importance of identifying hypermobility, because there's more and more evidence of being it's not just a bendy body but a bendy brain, and the way that the brain is processing things in a slightly different way if you're hypermobile, and it's very highly associated with autism and ADHD. Language disorder, so we wouldn't be able to diagnose the language disorder in the assessment, but we would certainly get enough information to be suspicious of it, and then we can make a further recommendation around that. Fine motor difficulties, so that we might pick up when we're seeing the child doing the handwriting exercise. Anxiety, low mood, very common, particularly anxiety if you're autistic ADHD. It's a very high risk of having a coexisting anxiety, which can be quite complicated and really challenging to overcome. Rejection sensitive dysphoria, which is really important to identify because that makes everything a lot more complicated and makes some of the strategies even more important, and the way that people think about how they give feedback to children and how they support them when they've got worries or they've talked about feeling upset because of a friendship issue, and us not minimizing that, because it can have massive impact on them and they can really become very distressed by that, and inadvertently we can make it worse. So that's really important. The demand avoidant profile.
You, before you go on from rejection sensitivity dysphoria, just to explain a little bit what that means in case people haven't heard that term before.
Okay, yes. So RSD, from what we understand of it, it's thought to be kind of unique to ADHD, but I have occasionally seen it with a child who I'm pretty confident is not ADHD but is autistic. And it is a very intense, unpleasant feeling that you get if you've done something wrong, you've been criticised, you've been left out. So because of the nature of the challenges that you have when you're autistic ADHD, you have many more risks of being criticised, getting into trouble, getting left out. And it triggers this really unpleasant feeling. That's very distressing, that people talk about. It's as bad as a physical pain, and it manifests with either extreme distress or can be negative emotions, anger towards the person that has criticized or left you out. And we can make it worse, because what we can accidentally do is kind of criticize more and minimize the distress. So if a child comes home from school and has been upset by a peer, we might say, that's a silly thing, don't be so silly, that's a silly thing to get upset about, and kind of dismiss it, with the best intention, but actually that fires up the whole process again. Whereas if we know about it and we can say, well, I'm really sorry to hear that must have, because we know how sensitive your brain is to these things, that must have been really painful to hear or really horrible. What can I do to help you feel better? It would leave you with a very different feeling. Yeah. So we see that an awful lot, and sometimes that's what is causing most of the distress and overwhelm. So that's very important to identify. The sensory processing difficulties, auditory processing difficulties. Again, we can identify enough about the sensory processing difficulties to be confident they're there, but to really fully understand that, you need a detailed occupational therapy assessment, because it's so complicated. What is driving one thing or sensitive to another, and then that informs the kind of sensory therapy that you may need and respond best to. Auditory processing, we would be able to sort of be suspicious of it, but again, not be able to diagnose it, but be able to signpost on.
Yes.
The demand avoidant profile, tics, what else? I think that's pretty much covered it.
Yeah, you mentioned pathological demand avoidance there. Do you just want to say a little tiny bit about that, just for people who are not familiar?
Yes,
with?
so I think increasingly I'm seeing children who are extremely demand avoidant, but it may not be pathological demand avoidance. Sometimes it is they're avoiding and saying no to a demand because they are so overwhelmed and stressed. They have no capacity to actually execute that demand. So it's coming from a very different place. PDA is also anxiety driven, but actually a true PDA profile, you tend to, there's just a slightly different flavor to the demand avoidance, and actually it can be quite sophisticated and use an awful lot of cognitive energy in trying to get out of the demand. It's one of the things that's so frustrating for PDA people, is that it'd be so much easier to just get the job done, but actually you spend so much time and energy finding ways to avoid it, even something that you want to do. And we see children, even from a very young age, have some very sophisticated ways to get out of doing what they've been asked to do, to the extent where sometimes the two professionals in the assessment will suddenly sort of think, my goodness, like we have just spent 10 minutes talking about something completely random and doing another activity in response to this request to copy these shapes out. And the child is so sophisticated at doing it, but it's a very different, but it's important, very important to identify, and to particularly the extreme demand avoidance profile, because if that's happening, that is a sign that this is a child who is heading for a crisis, because they are losing, you know, that capacity to function and meet everybody's demands.
And it can be very challenging for parents to know how to manage a child who's resisting all requests for everything at
Yeah,
home.
absolutely. And I think, you know, many parents will have worked out that the only way that they can actually support their child is to reduce the demands, but that can feel quite scary to take, to give control to a child and feel like that is not good parenting. But actually, if you have that identified and you have that reassurance that this is absolutely what you need to be doing, it can make a huge difference.
Absolutely. And in occupational therapy, from the sensory perspective, these children often have very, very significant sensory sensitivities that are driving their anxiety and their resistance to engage in activities. And they can have problems with coordination and planning and executing motor tasks. So they can really avoid requests to do something they know they're going to find hard, which is, you know, it's completely natural response if you're not feeling safe and
Yeah,
not confident.
absolutely.
Yeah.
And it's just trying to unpick as much of that so that you can really try to understand what the barriers are for this child and what needs to change to make things easier for them. It's not you know, I think you can go to lots of places and just get the answer about autism or ADHD, but actually you need to really be effective in supporting a child. You need so much more than that.
Absolutely, absolutely. One of the things that I know we've been seeing more and more at Starjumpz, and you've been doing a lot of work on and supporting, is autistic, and neurodivergent burnout. And that's something that you're coming across quite a lot as something that comes with this kind of assessment sometimes.
Yeah, so absolutely. So sometimes we will be seeing children who've not had any previous assessments who are presenting in crisis with a burnout picture. And obviously, if we're then identifying that as well as the diagnosis, we would be giving all of the advice and information on how best to support this child, not just from a neurodevelopmental point of view, but from the burnout perspective. Sometimes we see children where parents know they're struggling and they're resisting school, but they've maybe not realized actually what a red flag this is to this child in terms of risk of burnout. So that might be something we would be able to identify. But I'm also really keen, and we're going to plan, I think we're planning another talk about this as well, aren't we? Because I'm developing this sort of traffic light tool for parents to use for a child who has diagnosis of autism, ADHD, or both, as a sort of an awareness and hopefully prevention of burnout, because this is a frustrating thing, is that if we knew and we had more knowledge about it and people were more aware, there would be so much that could be done to actually avoid burnout. And when you are in burnout, it's catastrophic. So we need to be really proactive and developing ways to help people be more aware of it and have steps to put in place to prevent it.
Yes. So if a parent wanted to know what they need to be thinking about if they're looking for an assessment, what would be the main pieces of advice you would give to them if they're thinking about, should I take this step? What do they need to know?
Yeah, so I think we see all sorts of families at different sort of places in their journey about understanding neurodevelopment, and we can have absolutely expert families, maybe have got other children who are neurodivergent, who they've worked it out already, but they need our help to be able to formalize that and to put that all together to help with the evidence and the suggestions. And we might have families where they've just got a concern. They know their child is struggling. Somebody else may have suggested that this could be an underlying explanation, but actually they're at the very kind of infancy of their understanding. And actually it doesn't really matter where you are, but I think if you're unsure about whether your child sort of needs that full assessment, then we've got other ways that we could guide you with that. So if you were one of the appointments we have is an initial consultation where we get all the background information, the same information as we would have for a full assessment, and we meet the child and we do a few of the structured tasks, but we don't do the ADOS or the QB check. So it's a shorter appointment, but it's enough that we can work out whether there is, a strong likelihood that the evidence is indicating that you'd likely to get a diagnosis or not, or whether actually at this time, for whatever reason, it might be better to wait. But it would also bring some recommendations. So that's kind of a good starting point if people are unsure whether they need this full assessment. We also sometimes have families where they've already had an assessment for maybe autism or ADHD, but they're suspecting that this doesn't actually fully explain. And we have different types of appointments where we can do everything that we would be trying to do in a full assessment, but because we maybe don't have to do the ADOS, or we may not have to do some of the other bits, it might be a slightly shorter appointment. But actually, if it just depends, but we'd always be trying to be flexible and to kind of give as much information beforehand, so that when you come for the assessment, it is really, you feel like it is really worth it for you. And and we don't want people to walk away without their questions answered. It would be very unusual. We do have children where we can't reach a conclusion, but we'd always come up with a plan and recommendations. And that could be, sometimes I end up going and doing a school observation afterwards because the evidence is really confusing, and that can be really helpful. Or we might say, actually, we can get part of the picture and give as much information and advice as possible, but actually we also need a bit more time to see what happens. But then we would make a plan, and there would be the option of a follow-up, which wouldn't be as again, it wouldn't be as lengthy as a full assessment. So there's lots of different options.
Yes, that's really, I think, helpful for parents to know. And sometimes we have children that might come for help with their language and communication, their speech and communication, as a first starting point before they then decide to go forward, or for occupational therapy and sensory support. So there's lots of ways that we can give some help. And what age can you start from in your, what's the earliest you would see a child for an assessment, would you say?
So I've actually assessed an 18-month-old child who had a sibling who's autistic, and parents were very knowledgeable and observant, and they'd had a lot of concerns, and actually was very strong evidence. it's maybe not as it serves the purpose at that young age, I guess, for answers for the family, but it's in terms of future advice, it's not as helpful, because what you're expecting a child to do at 18 months, you can't see the extent of their challenges. So if that was the case, I'd always recommend a follow-up later on, like before entering primary school, so that we can get more of an idea of that child's challenges at that point. But I would say we see quite a number of 2-3-year-olds for an autism assessment. The ADHD assessment is a little bit more complicated. A lot of services won't assess children for ADHD until they're 6, or some services 7. There is no rule actually about that. And interestingly, the NICE guidance has a whole section on the management of ADHD in under 5. So if you weren't sort of allowed to diagnose ADHD in under 5s, you wouldn't need that section, obviously. So but the younger a child, the more difficult it can be to be completely certain that what you're seeing is ADHD, because sometimes it could be more of a sensory seeking profile, or sensory overwhelm, an autistic picture with extra challenges from sensory processing difficulties, or language difficulties, communication difficulties. But sometimes the evidence is so stark. Sometimes it's not necessarily the challenges that you see that can make you feel more confident that you're seeing ADHD as well, but it's the strengths that the ADHD brings that kind of oppose the challenges that you see in this child from an autistic perspective. And there's also extra complexities when you have both that can be really apparent from a young age. So it's still really important that we don't miss that from a young age. But if we do see a child where we're not sure, and that is the reality, it's not all, the evidence is not always clear cut for the ADHD side of things particularly, then we would give as much advice and recommendations to ensure that we're not missing a support need, but not be able to confirm it. But then we would say, be saying, actually, we do feel we need to see this child again in the future.
Yes. Yeah, that's really helpful. We have a question. Is it worth following up with another assessment? If a parent is saying they had an assessment with the NHS, but only autism was looked at, if they wanted to explore further, what would your advice be?
Yeah, so we have different options, but we do have an ADHD only assessment, and I think that works really well for a child who already has their autism diagnosis, because and we have different ways of doing that, but actually what works well is our 2-stage model, where child comes and they do the QB check with one of our neurodevelopmental practitioners, and they take a really detailed history exploring the ADHD challenges, and then they have a second appointment. It's usually a couple of weeks later, with one of the paediatricians, who then does the extra bits like the BPVS screening of language, the physical examination, and then writes a report that is not just confirming a diagnosis of ADHD if that is the outcome, but is bringing in the impact that that child's autism is also having on their profile. So because that is probably the most important thing that you need in some ways from the assessment. But there are also, alternatively, you can have like a single assessment, or with the paediatrician, one appointment that looks at, because it might be that you have had a concern about ADHD, but there are also other things that maybe with the assessment you've had before, they didn't have the time to cover, or it was confined to autism. So it might be that you've also got a concern about burnout, or demand avoidance, or developmental coordination disorder. So that would obviously take a little bit more time, but we would try, we don't want things to be missed. So we try to be as absolutely thorough as possible, whatever the assessment is, if it's an ADHD only one, because actually it's important to look at everything in just the same way as we do that in the full assessment.
We've had a question, have you ever seen diagnosis change over time that you've seen in the class?
So I would say that there are a number, so this has happened to me several times, where I've seen a young child, I've done, with a colleague, really detailed assessment, being confident at that time that child has ADHD, but they're not autistic. I haven't seen that, parents are not giving me any evidence to suggest autism, school aren't, and I haven't seen it in the clinic. And they have their ADHD diagnosis. Sometimes they may go on to ADHD medication, and then that in time, parents and school might start to see more behaviours that they are thinking are more indicative of autism. And then when I've seen the child again, whether they're medicated or not, it can happen in a medicated child and it can happen in a non-medicated child, just changes with age, because the combination of autism and ADHD is so complicated. But I've missed that not missed, but the evidence has not been there.
Yes.
And it's unusual, but it happens. So, there is something called diagnostic overshadowing. If you have a child who's very strongly ADHD, you can really easily miss the autism. They're not presenting with it underneath.
Right.
It becomes much more apparent as they get older, but it's still really important to re-explore. And I would say also seen particularly autistic children who have a more inattentive, sort of internalized ADHD presentation. Particularly if they're bright, then they can get through primary school without the ADHD having an impact and kind of appearing, because they're clever enough that they don't need to be concentrating in class. And so what then will often happen is that when they move to secondary school, and there's so much more information they're having to process, you can see things get much harder. So they might present with more anxiety or more stress, or they may have been really highly achieving in primary school, and then actually they're not maintaining that trajectory, and people start to ask questions about that. And then you get and ADHD symptoms can appear any time up to the age of 12. So actually they may just never have been there when they were younger. So that's important to be aware of. And also, it would be unusual, but I have had a few children where they've had a diagnosis from a very young age of autism. And then actually as they've developed, people have questioned that. And they're usually children where there's other things impacting. So I would say language disorder is probably the most likely kind of situation, but where perhaps the impact of that language disorder has manifested in a way that people have suspected autism, but actually when you re-look, the evidence isn't strong enough. There might be a few traits, but so I've had children come with an autism diagnosis where people have questioned that over the years, and then we've actually reassessed and taken that diagnosis away because there wasn't the evidence and it no longer made sense. So yeah, various things can happen.
Yes.
But I mean, typically, if the evidence, if the assessment is robust enough and the story makes sense, the evidence is there, then autism and ADHD are lifelong conditions, but the way they impact can change in time. So that's important to be aware of.
Thank you. I've got a question. Do you have any tips on getting an autistic child to be more open around their struggles? And the parents saying their child withholds serious things sometimes, and they're worried this could harm the child. That the parents promote open communication and a safe space to talk, and have given their child a special book for big feelings. But do you have any tips on how to help them to be more open about what's difficult for them?
Yeah, and it's quite a common situation. Can happen for lots of different reasons. Sometimes it is almost like seems to be like a block that actually that young person's brain hasn't realized that if I share this concern with a parent, I might feel better. So it doesn't occur it doesn't occur to them that somebody else might understand that.
Right.
it can be because they don't know how to start the conversation or feel really awkward about the conversation. It can be because maybe they've got this feeling, but they don't know why they're getting it and they don't understand it. So they actually don't want to talk about it because it's so confusing, and they don't want to sort of appear that they don't know what's going on. One of the things in the assessment in the ADOS is there's a number of series of questions exploring emotions. You know, what makes you feel happy? How do you know you're happy? Do you get a physical feeling when you're happy? And we also use, for children who are old enough to complete it, which is after the age of 7, we use something called the MAIA, the awareness of interoception. And it's amazing how many children don't get a strong sense from their body to help them know whether they're tired, hungry, stressed, happy, sad, worried. And they can't make that association with the physical feelings that might alert them to the fact that actually they're quite frightened about something. So sometimes, again, it's that connection. I think just keeping the communicate, having that space, maybe encouraging them to text if it's really difficult to, and it could just be a code word that can alert, because sometimes once a parent starts chatting about something, it's a bit easier for them to then share. Sometimes it's quite helpful to sort of separate it. So, using that approach of, I wonder if, or have any of your friends had this worry, or using a pet or a character that child identifies with to kind of explore, so it's a little bit separate from them. And sometimes through play, depending obviously on the age of the child, but it is something that we hear about a lot, and actually then we will see that evidence in the assessment, because we'll see how hard, but that can help us to understand a little bit more about what the barriers might be, because there can be obviously multiple barriers to why that they might be internalizing things.
Thank you. We have a question. How often have you come across children who have a diagnosis of ADD with autism?
So that's a really interesting and challenging question, and I spend quite a lot of time thinking about that, because when we are assessing for ADHD in isolation, we are looking for evidence of a combined presentation or an inattentive. So the inattentive, the terms have changed a little bit with the DSM-5 that came in 2013, but we used to use the term attention deficit disorder. We don't, technically that doesn't exist anymore. Everything is ADHD, but it's then subcategorized as a combined presentation, which is where you see the inattention and the hyperactive impulsive symptoms, or it's called ADHD predominantly inattentive presentation or subtype. When you have a child who is autistic ADHD, I think it's really difficult to distinguish. So I try to avoid actually committing to that, because I don't know that it's that helpful, because a child's way that their ADHD manifests changes. If they're autistic ADHD, it really changes depending on the context and environment that they're in, or it can even change minute to minute. We can see children who are so busy and active, they're like a whirlwind for like 2 hours of the assessment, and then we start a task that they're interested in and they are completely focused and still. And likewise, we can see a child who starts off the assessment really quiet, contained, looking focused, and by the end of the assessment they're doing cartwheels around the room and every item in the cupboard has been emptied. If you used your evidence from the first part of the assessment, you'd be thinking more of what we would used to refer to as ADD, or an inattentive presentation. But actually we've missed the fact that they can also have moments of hyperactivity, and you'll often find that parents will report much more hyperactivity than school will. But also it changes as a child gets older, so it's much more, typically children will find strategies to minimize the hyperactive impulsive elements. Comes at a cost, but you can risk if you base it on what you see, again, missing that. And then also more commonly in girls, but it can also be in boys, an internal presentation that can look like it's inattention, but you miss the fact that the hyperactivity is a kind of overthinking, constant busy brain. And if you don't recognize that, you're not going to be able to give all of the advice and support that is really going to make a difference to that child. So I think it's almost, I think in the future we will have, I think the term AUDHD is quite helpful, but maybe we'll have a different term for it when it is autism and ADHD together, because I do think that the ADHD is almost a bit different from a kind of traditional ADHD on its own, if that makes sense.
Yes, thank you. How do we explain, or how should parents explain their child's diagnosis to them? I know that in some assessments where it's appropriate and you've explored it with the family, you will talk to the child to help them understand. How would you approach that?
Yeah, so one of the things that I would almost universally do at the start of the assessment is either if I'm getting a sense the child's quite comfortable already and is chatty, I will ask the child, what have mum and dad said to you about why you were coming today? Or if I feel like that would be too much too soon, I say to the parents, can you tell me about what you have told about why Johnny has come here today? Yeah. And a lot of families will have already had that conversation, and the child will absolutely know that they're coming to find out, it would be in a very positive way. We've explained that child's coming here to find out as much as they can about their brain, why their brain might be a bit different to some people that they know, but they've also got a friend who's autistic, so they've wondered about autism or they've talked about ADHD, and they're coming today to find out more about that. And that's always a really positive way, because then also that they're expecting something at the end. They've already used those words, so it's probably going to, the family going to be quite comfortable with those words, and they kind of maybe will be expecting an outcome that might be one or the other or both. But sometimes families will come and they'll say, and for very good reasons, that they've not, their child is very anxious or very resistant to thinking about anything, and obviously depends on age and the level of understanding. But sometimes they might say, and this could be for a much older child, we've told our child that all children have this test when they are 8 years old, and I find that's difficult because it's not true. And so it's actually then unpicking that, because, and I think I said in the talk about how I feel, children they're not silly, and they know, and they're very aware of what's going on, and they want some kind of feedback. But I also would fully respect if the family are not ready for, or feel, they know their child best, they don't feel they're not ready to hear the full story yet. But some feedback is really important. If they've managed to do the QB check, that's a really nice way of starting to explain a little bit to them, because it's very visual. They can compare themselves to what I call boring brains, and there's always strengths to identify, yes, and to show them how brilliantly they've done at something. And so that can be a nice way in to say, look, these are the things we've seen that you're really good at, but actually this is quite difficult for you, and this might be why you don't like science, or you don't like maths, or this might be why you're finding it difficult to sit still in school, because they would have said something about their difficulties, or maybe they haven't, and then you've got to, then if they've been very defensive around there being anything they're struggling with, you need to obviously keep everything very positive, and that's then more conversation for another day. But sometimes, especially if parents are not, they've not yet come to terms with everything, and their knowledge isn't as well developed, they need time to because I always think it's very important that parents are actually well prepared for this, because their child's going to have questions, and they need to be as positive as they can in their answers. Yes. So I think if you can, it's good to do some kind of preparation, but it doesn't matter what words you've used, but there is something that you're expecting to find out about yourself. And it is also really helpful to warn us in advance if there's a particular thing that you're concerned about, with that feedback. And we have lots of different ways of doing it. And, sometimes by the end of that assessment, families and the child are, they're done and they can't take in any more, and that's fine. And then we can finish a bit earlier, and we can arrange to have that feedback via video link later. So always try to meet what's going to be best, adjust to what's going to be best for the family at that time.
And I think, we get a lot of feedback of a sense of relief for the child and for the family of, understanding strengths and what is difficult for the child. And, we often hear as therapists who might be seeing the children in occupational therapy, a child will say to us, Dr. Siggers really gets me, and it might be the first time that they've really felt that they're seen and understood, and it can really hugely impact their self-esteem and their ability to feel more able to face what is difficult for them, knowing, that there are, huge strengths and abilities that they have. Because I know that you put a very neuroaffirming and a very positive, empowering delivery on the way you communicate with the family and the child that I think is so important.
Yeah, absolutely. And I would say that my sense is more often than not, it goes well, and they leave with a sense of relief and explanations, but it doesn't always. And sometimes parents are really shocked by how that has gone and weren't expecting it. They were thinking that their child was actually going to be okay with hearing this, because they could have had all those conversations and actually prepared their child really well. But then when it comes to it, the child actually is, quite distressed about that outcome. But then we try, it's all we try really hard to, it is, always focusing on strength first and wrapping up anything that we are talking about as a challenge we feel needs to be acknowledged with positives either side of it. But sometimes we have to say, because you just occasionally have a child where you're pointing out even a strength, and then they say, no, that's not me, and you just know that actually they're getting quite defensive about it. It's getting stressful, and then you have to find a way to actually then end the conversation, talk about something else that they've done that's in the assessment really well, and then leave that conversation for another day. So I think we try very hard to be as sensitive to that as possible, and like reading the signs of and looking to parents, and if sometimes parents will say, we're really not sure how this is going to go, and then we might sort of say, well, look, let's have a code word. If you say this, we know that is, you don't want this conversation to go any further, and we'll find a way of wrapping everything up and revisit another day. So if as a parent planning an assessment, you're already concerned about that, just let us know, and we will accommodate that. Sometimes parents they really don't feel that their child is ready to have any feedback, and they will have created a scenario where then the child is not even aware that there is feedback, because a grandparent has come to collect them and there's a special treat. And then they don't actually even know that parents are staying back to talk, and that can work quite well.
Yes, I think that's really important. And sometimes parents may not be on the same page with how they view their child. And that obviously is something that is part of what you have to take into consideration when you're assessing a child. That can sometimes, be quite difficult.
Yeah, so and that can happen in a family that are together living in the same house, where there can be a difference between parents' views, and all very genuine, because actually one parent, it's not that one parent is wrong and the other is right, it's that one parent is seeing a different presentation to the other parent. And there can be, particularly when a child is autistic ADHD, that's quite common. what's a little bit more complicated is where you have separated parents, and they maybe the presentation that they see is even more different. And again,
Yeah.
it's not, and we'd always invite both parents to submit the same information and questionnaires and really take both into account, because it has to make sense, in terms
Yeah.
of the presentation. And there can be some very clear reasons why that there might be that differing, just in the same way as a child will present differently in school to at home in a lot of cases. But for the child, hearing that the outcome, it's so important that it's positive, and that it parents are, it's much better not to say anything than a child be then witnessing a discrepancy between, one parent saying, oh yes, this makes sense, and the other saying, no, that's not you at all. That leave a child in a very difficult position.
Yes.
So I think if there is, if there's this, it's really hard, because sometimes actually the child is saying they know that this is, especially an older child, they've worked it out themselves. They know that there is something different, and they want answers. And so you have to then, that's an opportunity that they're in front of you, and you could really help them to understand that. So you have to take a view that actually I do need to give some feedback, but caveat that hopefully there is, parents respecting that at that time, and that's then the
Yes.
conversation they can have later. But it can, it's difficult.
Yes, and I think the whole process can be very challenging for parents to go through the assessment process, and it's important to consider their needs as well, and for them to have opportunity for support.
Yeah, absolutely. Yeah. But we also have lots of different ways that we can, and there will always be a time during that assessment. It might be it depends who I'm doing the assessment with, that we have slightly different processes, but there will always be time during that assessment where the parent has the opportunity, unless the child is really, really anxious and can't separate from the parent, there will always be time to have a conversation with the paediatrician without the child there. And if it hasn't been possible, then we can do something afterwards on a video link to talk, more, because there are often things that parent wants to know more about that wouldn't be appropriate or helpful to talk about in front of the child, especially after a long assessment.
Yes. We've had a question as to whether neurodiverse conditions can be hereditary. Can autism and ADHD be hereditary?
Yes, absolutely. We know they're hereditary, but we don't know exactly how they're inherited.
Yes.
But particularly ADHD, so there are lots of different figures around, but in general, it's kind of quite established that if you have a first-degree relative who's ADHD, so that would be a parent or a sibling, you're 8 times more likely to be ADHD. And there's some evidence to suggest that it's a stronger link with a mum who's ADHD, so a much higher risk of a child being ADHD if mum is ADHD. Sometimes through the assessment process, and the more that parents are then learning about ways that autism and ADHD can present, they will sort of start to suspect that one of them is ADHD, one of them is autistic, or maybe they're both autistic ADHD, and maybe that can be an answer to lots of confusion for them, reflecting on their childhood. And I've had numerous parents who've contacted me later to say, after the assessment for our child, I went and had an assessment and it was really helpful. So it's quite common to find, and sometimes it can be quite obvious to us, and sometimes it's not at all. So it's interesting.
Yeah, very interesting. Just a few more questions. We're nearly through them, but what do you wish teachers and schools understood better about children who have neurodivergent? Is there something that you wish schools were more aware of that perhaps we're not seeing as much as we'd like to see?
Yeah, so I think that it would make a huge difference if schools knew more about sensory processing and the challenges that the sensory environment brings to children in school, that they had much more. And obviously there are staff who are really well
Oh,
informed and
absolutely.
absolutely get it, but there are people who had no experience and no training in how neurodiverse children can present so differently. And I think one of the frustrating things is where you have a child who's actually being denied access to services because school are saying they see no difficulties. And sometimes they will say that when in another report they've highlighted a number of things that they've been concerned about. So that's frustrating because there are still NHS services where if they don't have the concern from school, they won't put forward a child for assessment. So it can be a real barrier to actually having your needs understood. I think the challenge where you have a child who is presenting as fine in school, compliant, calm, and very different at home is still, I think there's more understanding of that, but it's still poorly understood. And schools needing to acknowledge that actually that dysregulation after school is a direct result of what's happened in school. And they will often say, well, they're fine here, so we don't need to put in support, but that is far from the case. So and that's frustrating because sometimes the things that would make a huge difference to that child are not costly things. They're just a different way of doing something. It's not like anything additional, but it's just a different way and it's not costly. And
Yes.
some teachers do that brilliantly because they've already sensed, and others don't. And there's so much, it's it's the children that are compliant in school and going under the radar that I worry most about, and they are the children that we see later as teenagers in burnout as
Yes.
such a high
Like
risk. And it
pressure.
does, it is, yeah.
Sorry, you go.
But I think also just in general, it's just for a lot of most of the strategies that you'd be recommending for an autistic ADHD child in school are strategies that would help all children and would not be
Absolutely. Yes.
harmful to a child who is not autistic ADHD. But if you use neurotypical strategies the whole time for a child who's neurodiverse, it is harmful. So
Yes.
that's frustrating because there is more and more evidence of the harm that school can cause to a child. It's not intentional, but it's the system. It, it's an archaic, for many schools, it's an archaic establishment that is not suited to a neurodiverse brain.
Yeah, absolutely. I totally agree with that. And often we might find that teachers are thinking that that maybe parenting isn't happening in the way it should because their parents are reporting meltdowns at home and difficulties at home and asking for accommodations in school like movement breaks and sensory breaks and like you say, the very simple things that could be implemented, but the school is not seeing the child that the parent describes. And so sometimes it's very difficult for the school to understand and appreciate what the parent might be
Yeah,
experiencing.
and and that absolutely, that still happens. And when we get the information from school, sometimes just the way that it's worded, that it may not be the case, but the impression that you're getting is that actually school are a bit suspicious of this story,
Yes.
and they're a bit dismissive of it. And I have never seen a child I've been doing this work now for 25 years. I've never seen a child where I would think that a family have made up the story to be kind of opposed to what is happening in school.
Absolutely.
And why there's always a reason, but I think it's very easy to think, well, that must be something that the parents are doing that is not suiting that child, and just the fact and missing and not understanding
Yeah.
masking and fight flight responses. But then it also, there are still children that I'm seeing that are getting in trouble for not sitting still. And that is also very, it's very frustrating. Even if they have an ADHD diagnosis, they're getting in trouble,
Yeah.
repeated exclusions, detentions, for things that they actually can't stop.
Yes, it's really, really.
And that's and we don't have these rules in the workplace that you have to sit still. I mean, there might be some jobs where you have to sit still for safety, but actually you go to meetings and people get up and it's fine, and they might have doodle and have blue tack to fiddle with, and it's completely acceptable. And they'll say like, and you'll be offered a comfort break every so often because it's accepted that it's really difficult to sit still, and that's for adults. So that's, but again, some schools are doing that brilliantly, and some schools are doing that, but they actually kind of miss the point of you can't wait for the child to ask for the movement break. And it's almost like, well, the response will be, well, they know that they can have a movement break if they want one, but it's just trying to get that that understanding that actually they may not even know they need one until it's too late, or they may desperately want to have a movement break, but there's no way they're going to ask. No. So a lot of the time you have that support which is offered, but it's completely inaccessible to a child. And so that's something that, needs to be understood more.
Yeah, we do try and do talks for schools, and we're always happy to try and support schools where they need training.
Yeah, and as I say, there are some schools, particularly around where we are in East Sussex, that are amazing at what they're doing, and they're spreading words to other schools, and it is fabulous. But there are also schools where it is worrying about what's happening.
Yes, absolutely. Somebody has asked, how damaging can it be to keep pushing an autistic child to do something they really don't enjoy doing in school? And can this ultimately lead to potential emotional-based school avoidance? It's very difficult for autistic children who are academically gifted to be fully understood, that they struggle with the more easy things that neurotypical children don't struggle with, which makes it harder for their age-related peers and some teaching staff to fully understand their diagnosis.
Yeah. You need autistic ADHD children need a very flexible individual approach. They have got such strengths in their brains, learning things that they're interested in, and the way and amazing, some of them amazing visual skills, amazing attention to detail, different interests, but once they're interested in something, a most amazing ability to retain great detail, factual knowledge. But some of what they're taught is completely irrelevant to them, and they don't see the point of it. It makes no sense to them. And actually, and I understand that, and isn't it, because the system is so rigid. But when I remember being at school, especially secondary school, often teachers would go off completely at a tangent because somebody in the class was interested in a particular aspect, and that was fine. It didn't matter if we didn't finish the syllabus that day. But now teachers are under so much pressure, and it's so rigid, they've got to get through these things. And it's a shame, because actually one of the ways, and one of the things we'll often recommend, particularly if a child is struggling to integrate with their peers, is using that interest and that thing that they're really good at to help them shine in front of their peers, because that can really help with the connection. And again, some schools will really do that and encourage that child to bring in whatever it is they're interested in, or do a presentation about, some of them have got the most incredible knowledge about things that can be relevant, to history and science, but they might not be the thing that they were having to focus on at the time. But it really needs to be a flexible approach, because actually some of these things that are kind of core syllabus stuff that to pass the exams they're going to have to learn are always going to be really boring and tedious. But if you can find a way they can learn that through their interests, they're going to be much more engaged in it. Yeah. So it's just it's just a slightly different approach that's needed, and a bit of flexibility a lot of the time.
obviously sometimes be much more challenging than that, but actually being forced to do something, constant demands, is just going to lead to more and more resistance. So it's not going to achieve anything, and it does risk causing more and more stress. And then how does that child feel if they're the one that's they might feel that they are the only one in the class that's constantly being asked to do the same thing, because they may not have made the connection that everybody was asked it the first time, or they may not have heard it the first time and that the other children were asked and they're getting on with it, but to them it will feel like they're being singled out. And a lot of autistic children have a very strong sense of justice and fairness, and then if they're RSD as well, that can really cause them a lot of distress if they feel that they're being picked on for whatever reason, and sometimes very justified.
Yes.
For them to feel that way.
And it can lead to them school refusing because it's just too stressful,
too much. And so it's just trying to find a different, if the ultimate aim is that you get from A to B, is how can you do that? That you might have to do a detour and go to D and come back to B, but that actually doesn't matter. But sometimes some of the rules, like I heard just recently, a child got into trouble because they'd done their homework in using a green pen and it needed to be a black or blue. And that is, ridiculous, isn't it? Because they've done the work, and actually we as adults, we celebrate that uniqueness and having a different approach to things, and then we somehow don't celebrate that in children and make them feel that if that child that day had a creative idea that actually I feel safe doing this in green pen, that's how I want to do it, I just think, isn't that wonderful? And does it really matter?
Yes.
And I know that's a basic example, but that sort of thing is happening in layers, and actually just need to be flexible and a bit more forgiving about things.
Absolutely. We've got a question. What should you focus on, or what should your child focus on, would you say, once they've got a diagnosis and recommendations? Is there advice you would have for the child and the family on what next?
So obviously depends on the diagnosis, but very, very important to have a positive understanding of yourself, because if we look at the evidence from adults receiving a diagnosis later in life, they will talk about actually quite a lot of trauma and damage to their self-esteem, that their child of not understanding why they did certain things, or why they couldn't seem to find something as easy as they saw a friend do it. They make a lot of assumptions that there's something wrong with them. They're bad, or they're mad, or there's just something. And actually that's so important to unravel and just be focusing on, it's just a difference, and that actually there's things that this difference makes you far better at, but they are things that are not easy to demonstrate in school. And I'd usually, if I am explaining diagnosis to a child in clinic, and particularly if it's an autism ADHD brain, I'll say, this is a brilliant brain to have as an adult, but it's actually a really difficult brain to have as a child who has to go to school. And I think that's important to acknowledge, because they know that school is hard and they're not enjoying it in the way that they might see other children. And it's a chore, and it's really difficult, not for all of them, but I think acknowledging that and helping them to understand that, and then saying, well, no wonder. And actually, when we see from this QB check how difficult it is for you to concentrate, and this was only for 20 minutes, how on earth are you learning in school? And we can celebrate that actually they are, because they'll feel like they're not achieving anything, and the messages that they'll often get are that they're not achieving. And so that is just turning that around and really focusing on positives, but also understanding, particularly for a child who's autistic ADHD, understanding the conflict that they get from that brain that is sometimes wanting to do the same thing in a completely different way, or actually saying no to something that they want to do and then not being able to understand that. And And that's also really important for families to understand, and just to be thinking, well, what's a different way that we can approach this so that we can actually make it much more likely that this child is going to be successful in whatever it is that they're wanting to do.
Yes.
Just might need a little bit of a different approach.
Yeah.
And it's not a wrong, there's no right or wrong, but they just might need things broken down, or, instead of putting a piece of homework in front of them and saying, right, you have to do this and you have to start at number 1 and you have to finish at number 10. If they're struggling to engage in that, giving them choice, saying, well, we've got this. Where do you want to start? Do you want to start at number 2 or do you want to start at number 6? And do you want to do this sitting in that chair or do you want to do it sitting or standing up? Actually, that can deflect from the fact that this is a challenging piece of work, and then they're doing it before you've realised. But if you are forcing them to do that, they're just going to say no over and over, and it's going to get more a more escalated response.
Yeah, absolutely. One thing we didn't touch on, I don't think, was children who might have attachment and trauma, looked after and adopted children with fetal alcohol syndrome. And that is an area that can be covered in a holistic assessment.
Yes. So if we have that evidence, then it obviously is really, if we know that a child has had some adverse early life experiences, it's really important we take that into account.
Yes.
What we have to be careful is not deciding, is this trauma or is this neurodevelopment?
Yeah.
Because you can have both, but it's trying to unpick that, and then trauma layers over everything and makes everything more complicated and more intense. But actually, a number of the recommendations. Again, if a recommendation or an approach for a child where somebody is thinking this is all happening because of developmental.
Sorry,
and difficult
I
for. Sorry, I don't know what happened there, but in a way that if you miss the autism and ADHD and put in strategies for, if you have missed neurodevelopment in a child who's also traumatized and you're very much focusing on repairing the trauma, and there'll be quite a push in some, not in every, but some programs would be very much a push to develop that relationship strength and connection. And if you've missed the fact that this child is autistic, and actually that is really difficult for them and stressful, and actually
apologise. I think we might be having a few internet issues. I seem to have lost Georgie. Hopefully she'll come back in a sec.
Can you hear and see me now?
I can see you now. Yes, you're back.
Yeah. So just trying really hard to unpick what is causing, what is driving what behaviour, and being as certain as we can to. It's almost, I think we need to, when we have a traumatized population of children, be excluding autism and ADHD because they're so at risk of also having being autistic ADHD because of genetic load and the circumstances that their parents may have been in that had led to them being removed from their care. But we can't ignore either. But it isn't a question of it has to be one or the other. We just have to work out a way that we can identify both if it's there and then support both. And it's also the same with, unfortunately, a lot of the children I'm seeing who are in burnout, they may not be getting better in the way that we would, or we're understanding that they should be from a burnout perspective. And actually what we're discovering more and more is that's because there's trauma there from school, and it's not like an intentional that anybody in school
Yeah.
has, you know, hopefully done anything harmful, but it's the system, the environment, the repeated demands and being misunderstood, the negative messages, and a loss of trust, particularly if they've been sort of tricked into school or forced into school. And that's very, it's really difficult, because if they're in burnout, actually sometimes the things that they might need to access to overcome that trauma, they can't, because they're not ready. So that's also something we have to take into account, and it can get very complicated.
Yeah, absolutely. I don't know if there's any other comments or things you'd like to say before we just close off, Georgie, about anything we've talked about, or anything you think we haven't covered that people might want to know. I'm just going to talk in a moment about the 2 talks we're doing soon, but is there anything you wanted to add?
I think the other thing that I would just say, that if you have a child who you suspect might have a neurodevelopmental condition, but actually they are very resistant to talking about that, acknowledging that, is that you have to really think carefully about the outcome of the assessment and whether that is in their best interest at that time. And because I think that can also be damaging, you know, if they're so resistant and then they're dragged somewhere, you know, sometimes against their will, you know, you have to really think carefully about why is it needed at that time. And there could be some very valid reasons why it's absolutely essential, because maybe they are very vulnerable and there needs to be some sort of extra protections in place, or extra access to different type of education provision, which they could absolutely, but you have to just think really carefully, weighing up the pros and cons. And I would say that there are things that we, you know, advice that we can do, and I've done that quite a few times. I've met a young person and explored the challenges. They're not ready to be thinking about a neurodevelopmental assessment yet, but actually we can identify, maybe just we can agree with them, and they might find it easier to accept that they're anxious, or that there's a particular thing that they're finding difficult, and then we can make some recommendations. And at least, you know, it's not going to be the whole answer, but it can be quite protective, and it's the start of the process. So if you've got any kind of concerns about that, then do reach out to us, because we can be very flexible in how we approach things. And also, if you have a child who you think is really going to struggle to come to the centre, you know, we've got social stories with pictures of Starjumpz and explaining the process. You can come and just visit. Sometimes people will just drive into the car park and drive away, and then they might come another day. And, you know, we'd always be open and welcoming to that, so that actually it is not an unfamiliar place on the day that you come. You know, if that's practically possible for you, we'd always be supportive of any sort of thing that you need to do. And you know, it is much, I think it's a better process if we can do the assessment at Starjumpz, but if there is a very, you know, clear need for that assessment and it's not going to be possible, then we would travel to people's homes. So there is, you know, obviously depending on where you are, but there is that option.
Yes.
And we're quite, you know, the equipment is mobile. We're lucky in that respect.
Absolutely. And actually, on that note, a lot of different organisations are offering online assessments, and I know very much that ours are in person. I don't know if you just want to comment briefly on why we favour in-person assessment.
Yeah, so I mean, we had to think really carefully about that, didn't we, when it was COVID, and we tried, and we did do some. What we did in the end was we did like part 2-part or even 3-part in some situations. So we would have an online meeting to explore all the concerns and do as much of what we could do that we felt was safe to do and robust online. And there is a lot that you can do online. But the real challenge is the ADOS, because the ADOS is not, it's not validated to be, it's only validated to be used in person. And it also with COVID, it wasn't validated to be used with a face mask, because it would interfere with that, you know, some of that non-verbal communication. We did do some online ADOS, and there are lots of people that would do that, and there's a lot of it that is perfect, you know, it works perfectly. But they're the nuanced things, particularly around facial expression and eye contact, that and also it affects the way that child initiates communication and social overtures, because it is just slightly awkward, isn't it, when you have to sometimes like have a pause so that the other person, you know, there's just delays, and it's a bit harder to judge. And so if that's something you're already finding difficult, it could sort of overemphasize that difficulty, when actually in person it would have been much easier for the child. So it's just trying to get the most accurate assessment. So I don't do online ADOS now, but I would do an online assessment for ADHD if I would like, you know, I think it's best to do it in person, and it's best to have the QB check, but I can do that. It all depends on the circumstances. I think for me, the type of online assessment that works best is when you've got a child who's really struggling to leave the house, and there's actually quite a lot that you can explore with them, with their parents, or even, you know, if they're a younger child, they're present in the background, and you can, lots of observations, and sometimes you learn a lot more about them seeing them in the safety of their home. And it's, you know, it would be better to be in their home with them, but that's not always practical, but it can work really well. But I would say that particularly if you have a child where the evidence is not, you know, it's a more subtle presentation, it's a little bit more complicated, there's masking, I think it'd be very easy to not get the true sense of a child's strengths and difficulties online.
Thank you. That was really, really helpful. We've covered a lot of questions and a lot of different aspects. I'm just going to show at the bottom how you can contact us by our email if you'd like more information or to book an assessment. And also, before we finish, just to mention that on the 7th of July at 7:30, Georgie, you're going to be talking about hypermobility with occupational therapist Olivia from Starjumpz. And then on the 28th of July at 7:30, risk factors for burnout. I don't know if you want to say a little bit about that and your traffic light system, the protective.
Yeah, so I want to basically do like a little bit of I've done talks about burnout before, but just like a little bit of an update about what we're discovering more about risk factors, and introducing, you know, that sort of idea of how can we prevent burnout if we've identified a child through assessment that we know is at risk, even, you know, if they're young and at that point there's no concerns about burnout, what can we have in place that actually keeps that child safe and thriving? And so to introduce, hopefully it will be, it's in its infancy at the moment, the burnout traffic light, but just as a tool for parents to kind of like just refer back to because sometimes they're not obvious, the signs that you can kind of have to reassure yourself that actually your autistic ADHD child is thriving. So it's just like the extra things that we see as early signs of burnout, and just having a way of actually putting in place some strategies so that you don't escalate into full burnout, and hope that, you know, that is something that people will find helpful. We can get your feedback from anyone who's like, you know, interested in using that, but it's something I can explain in that talk, and then we can share with people.
Fantastic, and there'll be an opportunity for questions. Could you just very briefly touch on the hypermobility talk that you're doing?
Yes, so Olivia is going to talk about the physical aspects, you know, the gross motor, fine motor aspects of being hypermobile and the extra challenges that brings to children. And I'm going to talk more about the kind of medical side of things and the brain side of things, particularly in the way that we are starting to understand hypermobile children experiencing threat, because it's something that is, you know, is only recently being understood, and it is again a risk factor for stress and overwhelm. So I hope that will be interesting for people. And I see so many of the children that I see at assessment are hypermobile, and something that is sometimes kind of not dismissed, but it's kind of I suppose the impact is minimized in a lot of cases, and we need to understand that more. So it's just exploring that and sharing updates around that.
Yes, I think the wider impact of hypermobility is not well understood. So it could be very interesting to other healthcare professionals and to teachers who maybe don't understand what the impact of hypermobility can be on a child. So I think that would be really
so I'm going to talk about the brain and also cardiovascular system, because there is a very strong link between being hypermobile and some very particular conditions that happen around the way that your brain is then regulating your blood pressure and heart rate. That can just be very unpleasant for children and add an extra strain when they're already have so much to deal with.
Absolutely. I'm going to really look forward to that myself to learn. Thank you so much, Georgie. That's really fabulous. Thank you to everyone who's asked such brilliant questions. We look forward to
thank you very much.
Yes, on the 7th of July and hopefully the 28th of July. So take care. Don't get too hot. It's in the middle of our heat wave right now. So good night, everybody.
Great.
Thank you.
Good evening. Bye.
Bye.